This is Lisa Ross, and I'm presenting my clinical teaching plan on LARC options counseling. LARC stands for long-acting reversible contraceptives. I have a teaching plan for patient care technicians that are called techs at Planned Parenthood of Metro Washington, which is PPMW, to improve the quality of their patient teaching and their contraceptive options counseling for patients. PPMW is organized so that the techs do education and counseling with patients before the patient sees the clinician. However, half of the techs have reported on the evaluation of their orientation that they feel inadequately prepared to counsel patients on contraceptive options. Clinicians have reported to administrators that they find patients have been misinformed about contraceptive options by the techs. This anecdotal finding has not been measured, but it is in alignment with the orientation evaluations. The orientation has never included training on shared decision-making tools. PPMW has noted that 20% of patients who receive implants have them prematurely removed in the first year of use. We have understood this to mean that their options counseling could be improved. PPMW set a goal to increase the number of women who choose LARC methods, are satisfied with them, and continue to use them. To progress to this goal, there is a training need for the techs who provide contraceptive education and counseling. This training will address the need to correct misunderstandings about LARC methods and to improve the quality of options counseling provided to patients, including through the use of a shared decision-making tool. LARC is credited with reducing the rate of unintended pregnancies in the U.S. Further reduction of the unintended pregnancy rate is a national priority, and increased use of LARC methods has been identified as an effective approach to this goal. Clients who are satisfied with the counseling they received when deciding to use a LARC method have been found to be more likely to continue its use. Moreover, LARC methods require a sizable initial financial investment. Premature removal represents a financial loss to the healthcare system. Lastly, Planned Parenthood has a national reputation for providing family planning care. The integrity of the organization suffers if PPMW staff misinform patients and provide insufficient options counseling. There are 4 patient care techs at PPMW. All of them will attend this training. Techs are not required to be credentialed as healthcare workers at any level. They are community members who are passionate about women's health. The team represents a diverse slice of the community. This is an advantage to PPMW because the team tends to reflect the demographics of the patient population. The goal of the training is to address the needs identified in the needs assessment, to correct misunderstandings about LARC, and the quality of options counseling provided by techs. The training objectives are to provide education on IUDs and implants, the 2 LARC methods, and to develop skills in using a shared decision-making tool. Several methods of instruction will be used throughout the training, but the highlighted method is role play. Training in the use of a shared decision-making tool will be provided through role play. Role play is a way for people to rehearse situations in preparation for a future performance and to improve their abilities within that role. There are 2 component parts of this method of instruction. First is role-playing a scenario, and second is a debriefing discussion. Role-playing a scenario provides a low-stakes environment where learners are safe to make mistakes while they practice applying theory to practice and build knowledge, skills, attitudes, and confidence in the new role they are assuming. During the debriefing of the role-play, learners have the opportunity to reflect on the scenario. This leads to further growth for them. I will present 4 studies from the literature on role play as a method of instruction. The first study by Gordon et al. Is a systematic review. This is level 1 on the hierarchy of evidence. It included a rigorous selection process to identify 22 studies involving an educational intervention to improve non-technical skills. The interventions studied included simulation and role-play exercises and observation. Key themes of the content of the interventions included communication, teamwork and leadership, and situational awareness. The next study by Hoffman et al. Is a randomized controlled trial, level 2. Its objective was to evaluate the effectiveness of a brief intervention for facilitating shared decision-making skills in clinicians and student clinicians. The intervention studied was a tutorial where a recorded role play was observed and then discussed. The intervention and control groups performed role plays of shared decision-making scenarios before and after the intervention. The control group was given written material only instead of including the role play intervention. The intervention group showed improved ability, attitude towards, and confidence in shared decision-making facilitation compared to the control group. The study by Tai et al. Is another Level 1 systematic review. These authors investigated the benefits of discussion groups and role play in medical education. The review included 43 studies and found the benefits of discussion and role play for students included developing communication and professional skills. They also found that it would be useful to develop guidelines for the use of these instructional methods. My last study is a Level 3 cohort study. It's a pilot study on the use of simulation-based training in care communication. Students observed role plays and participated in facilitated discussions. These interventions resulted in self-perceived improvements in knowledge, skills, confidence, and competence when dealing with challenging communication situations. The authors noted concern regarding the cost of this methodology. These 4 studies are considered high levels of evidence. They all identify development of communication skills, as well as attitudes, abilities, and confidence as benefits of role play. Also, they all noted a need in healthcare education to augment technical training with these components of professionalism. Each set of authors expressed unique concerns regarding role play, whether it be a need for further study of the methodology, a need for guidelines to inform the implementation, or the financial impact of using role play. Each set of authors role play was selected as the method of instruction for several reasons. The 4 diverse learners in the group have 4 different learning styles. Role play can address diversity in learning styles. It is a modern teaching method that is effective in developing professionalism. Key advantages in teaching people who have limited professional experience and who may be either burnt out on traditional teaching methods as being recent college graduates, or they might be unfamiliar with them. The goal of the training is to develop skills. Research has found role play to be an effective way to develop skills. My personal philosophy of education assumes that learners bring existing knowledge and experience to training sessions. Role play can address diversity in learners' backgrounds. Because role play is an active learning method, it allows the trainer to maintain the position of a facilitator or guide. Rather than transmitting knowledge, the trainer can support learners as they practice new skills. Changes in behavior and attitudes result from practice and scenarios. Trainers can facilitate discussions in the debriefing portion of role play to solidify the learner's growth. Role play aligns with the major components of my philosophy. Role play is a good fit for this group of learners because the group is diverse and role play is an inclusive learning method. It's also a good choice because it provides a safe space for active learning. Practical application is more important to these workers than an academic experience. It is useful for them to practice new skills without impacting patients. Dahlendorf has described how she uses role play to train learners in using shared decision-making. The first 2 objectives of the training address the need to provide accurate information on LARC methods. The content for Objective 1 is the risk, use, and benefits of IUDs. This will be provided to the learners in writing prior to the training session for independent study. We will spend 5 minutes to review this information at the beginning of the session. The risks, use, and benefits of implants make up the content for Objective 2. This information will also be provided before the training session and reviewed at the start. Trainers will listen for how knowledge of IUDs and implants is applied during the role play scenarios and use the debriefing time to address any misunderstandings noted. Training in options counseling with the aid of a shared decision-making tool is the 3rd objective. Role play is the method of instruction that will be used here. Learners will be presented with 5 scenarios that were prepared in advance. They will alternate between playing the role of the patient and the counselor. The diversity of the patient population and their concerns will be represented in the scenarios. The learners will be provided with a shared decision-making tool that was developed by the World Health Organization in order to facilitate their interactions with patients. Their use of the tool will structure the education they provide on LARC methods and improve the quality of the counseling that they provide in order to help patients choose a method. The role-play scenarios are opportunities for the learners to practice this new skill and appreciate the variety of priorities that patients bring to choosing a contraceptive method. The role-play scenarios will be followed by a debriefing time. Learners will have the opportunity to talk about how they felt during the mock patient interactions, and through discussion, they will solidify any changes in their beliefs and attitudes that occurred during the role plays. Increased confidence in options education and counseling should result from the entire experience. Evaluation of the learners will be ongoing during the role plays and debrief. The trainer will remain alert to notice any inaccurate understanding of LARC methods and attentive to evidence of professional growth. A post-test will be administered in order to measure learning. These sample questions check that correct knowledge has been gained and that learners understand skills necessary for shared decision-making. Learners will be asked to complete an evaluation of the training session and the trainer. They will assess the quality of the key components on a Likert scale. The additional resources provided for interested learners includes the shared decision-making tool that was used during the training, a summary of current knowledge on LARC methods, Planned Parenthood's resource for education and decision-making regarding birth control, and a link to a list of resources on LARC that the American College of Obstetricians and Gynecologists has curated. And here are the references that were used to develop this presentation.